Right. Excellent. Yes.
Okay, we can see you now.
Correct. Correct.
Okay,
So
so
should
good
we?
evening, everybody. I am Dr. Vidyanand Raut, and with me we have eminent orthopedic surgeon Dr. Milind Surwade. And welcome to all of you. Welcome to Ortho TV. On behalf of Ortho TV and Dr. Neeraj Bijlani, Dr. Ashok Shyam, and the entire Ortho TV team, I welcome all of you to this ongoing series, this webinar. Today we are talking on how to choose your implants in total hip replacement. So this is a very common dilemma that presents to us whenever we have a case, either any hip case, either a bipolar or a total hip. How to select the implants, which is the best possible implant in the given scenario. So if we look at the available hip implants, we have a we are spoiled for choice. We have a host of implants, and we don't know exactly which one is appropriate for any particular patient. So in this presentation, we are not going to attempt to promote any particular implant or any particular company, but we'll be taking some few names of some companies or some implants because they are the common familiar names to all of us, so that they will act as a prototype on which we can base our selection. Okay, so just a minute, yeah. There are. Let us start with femoral stems first. We'll come to the cups later. Basically, in the cups, the confusion is less because without fail, we should all attempt at uncemented hemispherical cups in every patient, every primary or revision patient. Okay, cemented cups are only a backup because they fail in 5 years. So cup is never a confusion. The confusion comes on the stem side. So let's talk of the stems. We have different designs or anatomical shapes of the stems that are available. Briefly, they are classified into these 6 categories. So the first one here is a tapered wedge stem where there is a single wedge. Wedge is wedge in only one plane. Okay. Then the second one, this type 2 is the metaphyseal filling stems. So that the example of type 1 would be a corail stem from Depew, taper lock from Zimmer Biomet. Example of a type 2 stem would be Summit or Synergy from Smith and Nephew. Then type 3, we have tapered round, tapered cone, and tapered rectangle. So if you look at 3B is a very commonly used stem. The prototype is Wagner stem. So it is a conical stem which is tapered in all 360 degrees. 3C is a tapered rectangle, which is not very commonly used, but we used to use that when I was training in Australia. This is called a spectron stem. Type 4 is the cylindrical stem, which is fully coated, which is made of carbon, cobalt chrome. The correct example is a solution stem from Depew. This is sort of going out of favor now, and we will discuss the reasons. Then type 5 is the modular stem, like the SROM from Depew, or we have the MRP Titan or Empyrean from Smith and Nephew. And last, number 6 is the anatomic stems, which are bowed to accommodate the coverage, the bow of the femur. So they come in right and left sizes. But with so many implants available, you can readily imagine that we this leads the sheer availability of so many options leads to confusion. So how to get out of this confusion? So the simple way is not to look at what is available. Let's look at what is required in a particular patient. So general rules: in all patients younger than 65 years must get uncemented stems. There are a few exceptions where we can use cemented stems, and we will discuss those. But by and large, patient less than 65 years try to get in a uncemented stem. The choice of stem is based mainly on the pathoanatomy and the quality of the bone. If the bone quality is poor, the canal is wide, you feel that the uncemented stem is not going to get a hold, then you should choose a cemented stem like that. Whichever implant you select, the implant must achieve fixation in the available best bone, wherever it is in the femur. Okay. So everyone knows this Dorr classification, type A, B, and C. So what is the difference? Type A is shaped like a champagne flute. I'll go back. If you can see, the proximally, the metaphyseal area is wide and the cortices are thick, so that the medullary canal here in this area, metadiaphyseal area, becomes very narrow. And this leads to a classical champagne flute shape. Whereas in type B, you can see that the medullary canal widens in this area. So this forms a cone. I'm sorry, the cone is not shown properly here, but it's a conical shape. It tapers down. Type C is called a stovepipe stem, where the medullary cortex is thinned out so much that it's like a huge thick pipe, which is called a stovepipe shape. Now, based on the available shape that we have to fit in our implants. Okay. So, for example, if we get a Dorr type A, you can see that it's a champagne flute shape, and a wedge of implant, a wedged implant, will fit in perfectly in that area. So that's what we call a tapered wedge implant will fit in type A. In type B, where we need more distal fixation in the cone, a conical implant would be more appropriate. And similarly, in type C, a cylindrical implant would be more appropriate. Okay. So let's get some examples. First is a wedge fixation in metaphysis. Second, type B is a cone fixation in metadiaphysis. And third is a cylindrical stem, which will get a hold in the diaphysis proper. The typical examples for type A are a tapered wedge stem, that is the corel. Okay. As you can see from the shape, it fills the available area perfectly and it is not going to sink. That is the most important point. Because it is tapered and corel is tapered in two dimensions, anteroposterior as well as mediolateral. Because the implant is tapered, it fits like a wedge and it cannot sink further. So we don't need a collar in most cases. Okay, we have collared variants of corel stem or corel-like stem available, but most of the times they do not have any indications. Non-collared stems work well. Then we come to the type B. Conical stem, the typical example is a Wagner stem. This is a workhorse stem, very versatile stem, more used in revisions than in primaries. But even in primary, we can use the same because the principle remains the same. Here, the difference between type A and type B is that fixation of the corel implant is mainly in the metaphysis, whereas fixation of the conical Wagner implant is mainly in the upper part of the diaphysis. And now we go to type C. The cylindrical stem, the classical example that we have is the solution stem. So this is a long cylindrical stem which fixes to the bone with the help of a scratch fit. Scratch fit means a fit all around, not in one area. And this stem is generally made of cobalt chromium. The other two are made of titanium. So again, which one to select in a primary situation? Say, for example, what we find is that 90% of the femoral morphology will be type A, and it will take the tapered wedge steps. Corel, Taperlock, Anthology, Accolade, or all the Indian companies have variants of these. Now, these stems can be coated with hydroxyapatite, or they can have a fully porous coating, or they can have a half porous coating. But that doesn't make a difference. The point I'm trying to make is the shape of the stem here. 90% of the times you will not go wrong if you choose a tapered wedge stem. So in most primary TKRs, this stem will work. The tapered wedge stem or a corel type stem will work. It will have a good metaphyseal fixation. You have to size it properly. You cannot undersize it. If you undersize it, it's going to sink and it's going to fail in retroversion also. So sizing is very proper. Because it has a metaphyseal fixation, it does not disturb the bone in the diaphysis. So it preserves bone for future revision. And this is an important point because we are dealing now with a primary THR or a primary or a bipolar. So we have the possibility that the patient may come in for a revision and it preserves the bone for any future revision. Okay. And these are the examples: Corel, taper lock, accolade stems. Now, let's quickly go to the cemented stems. So what is the role of cemented stems? Do we use or do we not use? Sadly, what has happened is that the cementing technique has become a lost art. We know that the old Chanle type stems or the Exeter type stems, they were done way back in the 60s and 70s. They used to last 35, 40, 45 years. And we have long-term follow-up, proven follow-up of that. But the key factor was the cementing technique. If you don't do a proper cementing technique, the stem would fail, the fixation would fail. Okay. The typical example for this is a C stem from Depew. Okay. Or from Exeter, from Stryker, we have the Exeter type. Both of these work on the same principle. They are collarless, polished, and tapered stems. So they work on the taper slip principle. They don't have a collar. So theoretically, it allows a little sinkage. And it has been observed that in the taper slip principle, what is the principle? Over the course of 1 to 2 years, the stem sinks within the cement mantle by about 1 millimeter. Does that mean it is loose? No, it is not loose. In fact, it gains more stability as it sinks by 1 millimeter. Okay. And once it regains that secondary position, now it is stable. So it gets excellent primary stability immediately after surgery and secondary stability. And the long-term survival data is excellent. Okay. All companies, whether imported companies or Indian companies, they have their variants available of the cemented stem. When to use a cemented stem? As I mentioned earlier, elderly patients above 65, the bone quality may not be good, and I would prefer to use a cemented stem in such patients. In bipolar hemiarthroplasty, again, most of our patients for bipolar are above 65. If we have a fracture neck femur less than 65 years of age, I would not be doing a bipolar. I would be doing a total hip. And in that case, I would be selecting an uncemented stem. But we are talking of typical patient of hemiarthroplasty who is more than 65 years old, frail, medical problems, poor quality bone, and we want to do a quick surgery but an effective surgery. Cemented stem is ideal. But look at the third point. The cemented stem is also used as a very viable alternative to the type C femur, Dorr type C femur. Instead of doing a solutions type stem, which has its own set of problems, we can do a cemented stem. The conical stem may not work there. The tapered wedge stem definitely will not work there. So that's why a cemented stem is a viable option in such patients. Let's now go to the cups. As I mentioned at the beginning of the talk, all patients must preferably get uncemented hemispherical cups because there is proven data to show that cemented cups, even if the cementing was done very meticulously, they fail in 5 to 7 years. So the midterm results are not good and they come up for revisions. Hence, your choice must be to use always uncemented hemispherical cup of any company. The survivorship data of uncemented cups with any type of coating, porous coating, HA coating, whatever, the survivorship data is very good. Technically, they are very easy to insert because it's a hemisphere. Okay. So you have to ream properly in line with the final position of the implant. Don't wobble. Don't put too much stress on the handle of the reamer. Don't ream inside medially too much. So do a proper pre-op planning. With all this technique, it is easy. And you get a catch in the anterior and posterior column. The size of the cup is decided by the distance between the anterior and posterior column, not superior inferiorly. Superiorly, it automatically will feel in primary situations. If not, if there is a toggle, so the cup is sitting well between the two columns. Excuse me. But if the cup is slightly toggling, you can add 1 or 2 screws. So the technique is to under ream by 1 to 2 millimeter, achieve a press fit, add screws if needed. Under ream and over stuff. That is the principle which we must follow. So most patients would get uncemented cups. Is there a role of cemented cup? Should we use? In 5 years, 7 years, they are going to fail. So when should we use? As a general dictum, when you're doing a THR or a bipolar, you should have cemented implants as a backup, both on the stem side and on the cup side. Because you never know when you are not achieving a fixation by uncemented methods, and you might want to augment your fixation. So cemented implants are always good. So as regards the cup, primarily you can select a cemented cup when the longevity of the patient is not too much. If the patient is moribund and elderly, and the patient is, say, 75, 80 years old, in that patient, maybe it is viable to use a cemented cup. So elderly osteoporotic patients in whom it is difficult to achieve a press fit, they are good candidates for a cemented cup. And so these are the standard attributes of a cemented cup. There should be a PMMA spacer, lip liner 10 or 20 degrees, an X-ray compatible wire, radiographic wire to tell us the version. There should be flanges, there should be grooves for augmenting our cement, and the diameter and everything. That's not a point for discussion. Basically, you should use 28 or 32 millimeter heads. But the take-home message is that use the implant and the technique that you are familiar with. Both cemented and uncemented implants will work well with proper surgical technique. Even cemented cups will work well in the short term. And if the indication is proper, then in those set of indications, even a cemented cup is justified. But you have to understand the limitations of each implant. Not all implants are the same. So final implant selection will be based on age of the patient, bone quality, the local bone morphology or pathoanatomy of the bone, cost of the implant. That's an important consideration in India. Cost of the implant and availability in your city on the day of the surgery. It may be possible that you want to do a surgery, you want to use a particular type of implants, but the company says, no, the set is in Delhi or Chennai and we don't have it available. So you have to check for availability also. So based on these factors, you select your implants. Be sure that you are familiar with the implant, the instrumentation, and the surgical technique. And so you can give a reproducible result every time. Thank you very much. Milind, can you hear me?
Yeah. Am I audible?
Yes, Milind, you are audible.
Yeah. Thank you, Vidyanand sir, for such a precise and very basic topic to explain in very simple words.
Yeah.
So may I have the questions from do you have the questions from the audience, or I can start asking you the questions?
Milind, you can start, and you'll get the questions in the chat box, I think. Poonam, is that correct?
I think I'll just message her once. Yeah. So I'll ask you the first question of mine. Like
Yeah.
you said about the collared stem and a collarless stem, non-collared stem. So what is the difference between these two as far as the intraoperative fracture incidence is concerned? Because now there is a literature which shows that the collared stem has lesser incidence of fracture, periprosthetic fracture intraoperatively. So any thoughts on that actually?
I generally don't prefer to use collared stems at all,
Okay.
as I said earlier. But yes, theoretically, what you are saying makes sense. When the collar touches the available calcar and we
Yeah.
see that it is touching there, we are not going to hammer.
Oh,
So
right.
the chance of fracture propagating is not going to be there or less. Whereas
Right.
if you are using an non-collared stem, in order to achieve stability, You don't know whether the size 5 is appropriate or 6 is appropriate. So you try with a 6.
6.
But
Yeah.
sometimes
Okay.
you go overboard and sometimes you develop a crack.
Correct.
Most of the times, a small crack in the calcar area is not going to be a problem. At the most, you can just wire it up. Sometimes even not even that. Unless the crack propagates beyond the lesser tuberosity, you are actually very safe.
Right. Right. Thank you, sir. And one more, can you give some tips on improving the press fit of the cup in a RA patient, like RA or ankylosing patient who has very osteoporotic bones?
Okay.
So, is there any tips like which cup we should use and how? What is your technique to get a perfect fit?
So again, we should use an uncemented cup if it is fitting there. Only if we find that we are not achieving fixation or not achieving stability with our trials, then
Right.
instead of opening the uncemented cup and wasting it and finding it at the last moment that the cup is not working, instead of doing that, then we can go for the cemented cup. But
Okay.
with proper technique, 99% of the times you can predictably insert an uncemented cup even in osteoporotic bone, even in rheumatoids, even in ankylosing spondylitis. Okay,
Yeah.
so the technique
Yes.
is line-to-line reaming.
Okay.
Uh, First, you must understand that the cup sits well. The size of the cup is decided by the available bone from the 3 o'clock to the 9 o'clock positions. That is from the anterior column to the posterior column.
Right.
Okay. So when you ream, so you start reaming. Suppose the native cup in a particular patient is say size 52. I'm just giving an example. You start reaming from 44, 46, 48. Now you start feeling that it is a bit getting snugly fit.
Yes.
50 is snugly fit. So then you go in 1 millimeter increments in the same direction. So 51 reamer, you find that it's moving but slightly catching. But once it
Okay.
starts moving, it rotates within the cup.
Yeah. Right.
Okay. So that's not your ideal size. Then you take 52. Then when the reamer catches, the reamer is not able to move. That is your size.
Size. Okay.
Okay. So in doing this, you have to be careful that you have to ream again. I'm stressing that point again and again. In the same direction, if you keep the handle on one side, then you will do an eccentric reaming and you can blow out either the anterior column or posterior column. You should
Right.
also, in osteoporotic bone, not put too much pressure. Sometimes you can
Yeah.
blow out the medial wall. So
Middle one.
you don't want that also. So you do a proper pre-op planning. First, know where you are going to place the cup. First, have an idea where you are going to put the center of rotation. Okay. And once you are reasonably sure, do a reaming. As I said, when the reamer catches, suppose 51 or 52 reamer is catching, it's not rotating. Now you take out the reamer, check
Right.
visibly and manually that all the kachra has been removed inside the acetabulum. Give a wash, slight wash if required. See to it that you have achieved a proper hemispherical shape. Okay. And now you can safely put an uncemented cup of 52. The
Right.
cup will fit. If the reamer was catching, the cup will fit.
Fit.
You put in
Okay.
the trial. You are happy with that. You should be reasonably happy with the trial. The actual stability which you are going to get with the final cup will be more, which will be much better because the final cup is generally half a millimeter
Little
bigger and
bigger than.
with the porous coating. So you are going to
Yes.
get a good stability. Okay. But when you put the final cup, you find that it is slightly toggling. You press the top of the cup and you feel that there is a slight movement. Then you add screws. Most of the
Yes.
times you don't need screws, but it is also a good practice. If you're not sure, you can always add 1 or 2 screws.
Correct. Yes. Like about the company, I like the cup type. I was asking, like
Huh.
say Pinnacle cup and versus there is one more I guess which has a better coating from the debut.
Huh.
So like, is there any difference between using those cups for a porotic bones? Like if you're normally using
So you're
Pinnacle
talking.
cups,
So
yes, I'm pardon.
so now Depu has the Duralock cup,
Yeah,
Pinnacle, and
Pinnacle,
the Gription.
Gription, yes, Gription that
So now the Duralock cup is no longer being
not
used,
used, but
but the Duralock was nice for shallow acetabulum. Duralock is a
160,
160-degree
60.
cup. So it is
Right.
not a complete hemisphere,
Right, sir.
less than a hemisphere. So if your depth of the acetabulum is not too much, Duralock works well.
Yes, right.
Okay. So in
Shallow
dysplasic
acetabular.
hips or shallow acetabulum, whatever reason,
Yes, sir.
it's a good idea to have Duralock if it's available. Most of the times for primary hips, we use Pinnacle. Okay. Now the Gription cup is same as Pinnacle, but with that coating, that
Coatings. Yes.
the Gription coating, the
Yes, sir.
trabecular metal coating. So the
Correct.
quality of fixation and osteointegration that we get with the Gription cup is much, much, much better than with the ordinary Pinnacle cup. However,
Right.
that does not mean that we should always use Gription cup. One thing, it is costly. We don't want to increase the cost.
First.
And moreover, if you use the Gription cup and if that patient comes for revision,
No.
when you remove that Gription cup, it will take away a lot of bone along with it. So
Yes,
you
sir.
will be dealing with a very big void in the acetabulum in your revision scenario.
Correct.
Removing a Pinnacle cup, plain Pinnacle cup without the Gription coating is easier and simpler.
Right, sir.
So that is the reason we should use Pinnacle cup in most situations. The added coating is to be reserved when you are not sure, when you are not getting full 60 to 70% coverage. The Gription,
Yes,
the
sir.
advantage of Gription
Oh,
is
yeah.
that even if you get 50%, 60% coverage, it's going to stick well.
Right, sir. Yeah. Thank you. Thank you very much. May I ask one more question? Like whether Exeter design, cemented stem, Exeter design versus a Mueller design. Nowadays they have Mueller design also in cemented. So which one is your preference? Like the C stem is kind of a Exeter type of stem, like the straight collared polish,
Yeah.
collarless, sorry, polished stem.
I prefer the Exeter stem, frankly.
Exeter design. Yes, sir.
Yeah. I'll tell you the reasons. If you see the profile of the Exeter type stem, the lateral wall is straight down.
Yes.
If your entry point is properly lateralized, then generally you find you never have any problem in getting the Exeter stem down into the canal. You don't have to
Correct.
negotiate it.
Yes, sir.
Ease of insertion is very important, and Exeter has, as you long-term data, survivorship data.
Perfect. I think I'm not able to get any questions.
Poonam,
Any other questions, Poonam? Are you there? Uh,
Yes,
I'll
sir.
just go. Poonam, are there any questions in the chat box from the
No,
daily?
sir. No questions.
okay, no problem.
Okay. So I think,
yes, sir.
Milind, we have covered most of the points which
Yes,
are
sir.
required.
Right, sir.
Most important thing we have to understand is the cost. Okay, we
Correct.
cannot go overboard, and the the final implant selection has to be based on age, bone quality, local bone morphology, availability
Yes, sir.
of the implant, and the cost of the implant. And that goes for the stem as well as the cup. The Indian companies are good. The bigger Indian companies like Biorad and Merrill, they are
Yeah.
good. Their implant quality is at par with the multinational companies.
Yes,
But
sir.
we should be cautious that there are cheaper versions available. I don't want to name them, so
Right.
they can have a problem of implant breakage.
Perfect. Perfect. Thank you very much, sir, for
Okay.
such a wonderful lecture, and very basic ideas got cleared in that. Thank you, sir.
Thank you, Milind, and thank you for hosting this.
Thank you,
Thank you,
sir.
Poonam. Can
Yeah.
you log out now?
Yes, sir.
Thank you,
Okay,
sir.
okay. We'll log
Yeah.
out. Thank you.
Yeah.